with the first talk on orbital infection, and I would like to invite Dr. Anirban Bhaduri for his talk. Dr. Bhaduri is a dear friend. He heads the, from very own Kolkata here, and he heads the Department of Orbit, Oculoplasty and Ocular Oncology at Sushruth Eye Care Foundation and Research Center. Over to you, Dr. Anirban.
Thank you, Seema. Thank you, Feroz and the scientific committee for having invited us here. I'll start. It's a tall order. We thought it was 10 minutes, and suddenly I'm gasping for breath. I'll be speaking about orbital infections and infestations. So to start with, these are inflammations caused by pathogenic organisms. They might be microbial, or they may actually be metazoa. Okay, the other thing is that these infections are potentially vision-threatening, and some of them can also be life-threatening. But also remember that there will be other inflammatory conditions which can mimic an infection. And last but not the least, you have the elephant in the room, that is the masquerades. So quickly moving on to orbital cellulitis, these are usually acute infections caused by bacteria, and they often come from neighboring structures. So the sinus being the most important, 90% of orbital cellulitis is actually from the paranasal sinuses, usually the ethmoid, followed by the frontal, maxillary being less common. It could also happen from a periodontal infection. Penetrating injuries are one possible cause. Of course, our dear lacrimal sac being another source. And then you might have distant spread of infection through the hematogenous route. Okay. The other thing is that the infections are more common in young children and then again in the elderly. And there is a difference in the microbiology spectrum as well. So children less than 9 years usually have a single organism infection, while older children and adults can have a mixed infection. Okay, how do you work these patients up? So the history is important, which would tell you how this disease originated, what is the duration. Vision being extremely important here because it's a potentially vision-threatening condition. So look for visual acuity repeatedly, color vision examination, as well as look for RAPD. Check for eye movements. Ask the patient whether the patient can experience diplopia, and of course measure the proptosis, because that would help you to gauge whether the patient is improving with treatment. Among the workups, you would do the blood counts, swabs from the nasal cavity, as well as blood culture, urine culture if you cannot find a local source of infection, and of course a CT scan, very important to localize the infection as also to rule out any sinus involvement. And of course you can do CRP and procalcitonin, which would also be markers for macrobiological activity. Okay, so with the scans you have a fairly good idea about where lies your infection, and Chandler very nicely did this classification way back in the 1970s. Preseptal, of course, is not a part of the orbital cellulitis spectrum, but it's important to know. And the worst condition, of course, being the cavernous sinus thrombosis, which is a life-threatening condition. If you look at orbital cellulitis, what distinguishes it from this situation where this child has a preseptal cellulitis is the proptosis, the movement restriction, and of course, again, attention to the pupil, attention to vision, and these patients also have a lot of chemosis. And always examine the tenseness of the lid. Can you open the lid freely, or is it taking an effort? And that is again something that you can monitor. Treatment is empirical, intravenous, broad-spectrum antibiotics, systemic analgesics to reduce the pain and the inflammation, and then would you give steroids? So generally what we do is after 24 to 40 days, if we find a response to the antibiotics, is when we start steroids to protect the optic nerve, protect the vision. So this is a child with classical orbital cellulitis, and this is post-treatment. Let's look at this situation. So this patient is a diabetic, presents with acute inflammation involving the orbit and has a lacrimal abscess. But you look at the scan. So this shows the inflammation arising from the sac. You have the fat stranding, which is typical of orbital cellulitis. You also have a subperiosteal abscess here, but very important. Look at the straightening of the optic nerve and the tenting of the globe. Now this is an ominous sign for vision loss. Again, treatment would be the same as for the previous situation, but here you would also do surgical drainage. Another patient who presents like this with an abscess which is extending into the subdural space. Again, the same principles, drainage as well as systemic antibiotics. Another patient with an orbital abscess. Now you could either do an open drainage under anesthesia, or what we learned from our experience with lacrimal abscesses, you can go in with a white bore needle and aspirate the pus from the abscess. And of course, again, systemic antibiotics and steroids at the appropriate time. Orbital tuberculosis is rare. This is just one patient where I had the experience of, we had actually diagnosed this as a possible tumor because there were no signs of inflammation. And there was a lot of bony abnormalities. You can see all these cavities that have happened. And then, of course, biopsy showed caseation. And this patient was treated for tuberculosis. Shifting gears to fungal infections. How much time do I have? 2 minutes. Okay. So we've all gone through this in the last few years. Mucormycosis. Dr. Honavar came up with this very elegant staging system. I'll just skip this fast. And the salient features, you have features of orbital cellulitis, but look for CRAO, look for any hypotony, which would tell you that there is an ophthalmic artery occlusion. Look for Eschars. So look at the nasal cavity, look at the palate. Does the patient have any stuffiness, pain along the face? Is there any bloody discharge from the nose? And in CNS extension, you could have facial palsy, patient can develop a paralysis, and these carry a very high mortality. Treatment is, of course, with intravenous amphotericin B. You have to control the diabetes, which is the underlying cause. Surgical debridement of the sinuses, debridement of the orbit, or even a exentration of the orbit. And again, the learning from COVID was that you can save certain eyes with transcutaneous injections of amphotericin B into the orbit. Okay, this is the other one, which is not fulminant, but this again can present with, this again has an underlying immunocompromised situation, which is where patients can develop an invasive disease. And this again is treated with intravenous amphotericin B as a first line of treatment, or if the patient cannot tolerate, with voriconazole, and then you can shift to oral voriconazole at a later stage. Now, this particular entity presents as an NSOID, so it is important to do a biopsy. Just as for a mucor, you have to clinically show that there is a mucor infection. Similarly here, you have to do a biopsy to establish that it's a fungal infection and then treat it accordingly. The last, we still have time. So 3 parasitic infestations that we're going to talk about. Orbital myositis typically presents with a myositis-like feature, so the eye does not move in the direction of the muscle involved. You do an ultrasound, you can show a cavity along with a scolex, or a CT scan could show the same. Some of these patients, if it's involved in the apex, can have vision loss. And it's important to treat them with both systemic albendazole as well as steroid therapy to reduce the inflammation that comes once the parasite is in its dying stage. Hydatid cysts are rare infections. You have this situation where you have a multilocular cyst with septi. This is a typical hydatid cyst, and you need to remove the endocyst. These patients can also be treated with oral albendazole over a longer period of time. So this is the last. We had, shall I stop? So this is something that we may not be very familiar with as ophthalmologists, but veterinary surgeons are more familiar with. And here again, you need to do an extensive debridement and then treat the wound accordingly. Thank you. We'll stop here.
Thank you, Dr. Anirban. I think it's a very huge topic, infection, and it's difficult to cover in a short time, but I'm sure there will be questions, and possibly we can take them towards the end.
So I think one of the major aspects has been myositis. Fortunately, it has come down now. Otherwise, at one stage, a decade ago, it was one of the commonest causes for presentation of orbital disease, proptosis or motility restrictions or something. So the change in scenario points to better hygiene probably.
Seema,
And
I have a
food
question
hygiene.
to Dr. Bhaduri and all the panelists also. In case of orbital cellulitis, it is recommended that you can start the steroid, systemic steroid. So what is your takeaway?
Okay, so systemic steroids is not something that you're going to give right at the beginning. Systemic steroids is controversial.
Not
I agree.
obviously.
So what we do is we start the patient on intravenous antibiotics and wait for a response. The clinical response would be reduction in pain, reduction in the swelling, your ability to lift up the lid, any improvement in movements, and of course reduction of proptosis. You look for clinical signs of improvement in the first 24 hours. If you don't, you probably have to change your antibiotic, right? And if you do, then that is when we start intravenous steroids. Give it over a short period of time to rapidly control the inflammation.
Suppose when it is not improving at all, within 48 hours, it is not improving, the patient vision is deteriorating, the RAPD is deteriorating, then what you are going to do?
What am I going to do? I'm going to refer the patient to you.
So you have to look for the
This is
cause.
when you need to change your antibiotic. Okay. So always remember with orbital cellulitis, you are treating a presumptive.
Our ENT, like one of the cases you showed is allergic fungal sinusitis.
Yeah.
Our ENT friends, they said that you start the steroid, IV steroid, and it worked wonderful. Because steroid works in two ways. One is that it reduces the inflammatory edema of the mucosa of the sinuses, especially when the sinusitis is the main thing. It reduces the sinus, it improves the drainage of the sinus. That is they are saying.
Ma'am, I don't agree with this. I'll tell you what, in this situation, what you would probably do is, your ENT specialist would debride the sinuses. Okay, do a, what do we call it? Clean up the sinuses, basically, improve the drainage of the sinuses, remove the pus from that direction. You also get a microbiological diagnosis. And then, of course, you change it.
Start the oral steroid first, then
Okay,
you do the
no,
procedure.
I would not agree with that.
They have
Dr.
done it
Usha,
and it worked
Usha wanted to say something, please.
Now, can I say something? I think we'll have to have a judicious approach to this. One, as Anirban had mentioned, that we start off with antibiotics. Probably on day 2, when things are looking good, we would supplement it with injections, IV steroids, and again that has to be judiciously used based on the systemic conditions as well. So there's no harm, and in certain cases you probably would simultaneously start under cover of antibiotics.
Yes, there are studies which have shown that the resolution of the delayed signs, like the motility, the proptosis becomes much faster with steroids, but the use has to be judicious, making sure that the antibiotics are having an effect. If you have an organism which is not sensitive, or probably you not made the correct diagnosis of bacterial or fungal or whatever, then the use of steroids could be harmful. So take it as a double-edged sword.
I think one take-home message, like in your presentation, would be, please do not start the antibiotics in cases of orbital abscess. A few of the cases where you showed, there was a subperiosteal abscess. Sometimes we tend to give the antibiotics and then try to drain the abscess. You will not be able to succeed because it will form an antibioma. So it's best to